So good morning, everybody. Thank you very much again for the kind introduction. So the task this morning is to talk a bit about the thyroid axis in relation to pregnancy and fertility more broadly. This is a 25-minute slot to cover something which the American Thyroid Association recently published guidelines which are about 180 pages. So we are not going to cover all of that in this time. However, I am going to try and pick out what I think are some important points which may also generate some debate. So there is no doubt about it that for an axis which we often think to be a relatively simple axis, the hypothalamic pituitary thyroid axis, once we are thinking about pregnancy or actively in pregnancy, there's an awful lot to consider, quite a lot going on. Many changes, many physiological changes, and a number of these have also got quite significant ramifications for how our endocrine laboratories actually measure the hormones which we are so dependent on in terms of judging whether we should be starting or indeed changing treatment. So here's a brief overview of the topics which I propose that we cover today. We're going to look a little bit at reminding ourselves about the physiological changes that occur in pregnancy and where these have ramifications for the laboratory. Going to briefly touch on issues around iodine requirements for pregnancy, talk about management of hypothyroidism in pregnancy, subclinical thyroid disease, whether we should be doing anything about that, the entity of apparent isolated hypothyroidism, whether we should be doing anything about that, thinking briefly about what we do in patients who are thyroid peroxidase antibody positive, and then I'm going to finish with an important illustrative case which shows that we do need to always think more globally than just the numbers that we're receiving back from the laboratory. So we need to first of all understand the context in which we're operating when we think about how to manage a patient in pregnancy with thyroid disease or suspected thyroid disease. So what are the important physiological changes which occur within the axis? What are the consequences for the actual hormone levels, the free hormone levels and TSH? And as I say, can we actually trust the laboratory and the results that they're actually sending to us? So the axis is a very classical axis. Hypothalamic TRH controlling production of TSH from the pituitary, driving T3 and T4 production. Now this is important because most of the T3 and T4 that's actually produced by the gland is actually circulating heavily protein bound, more than 99%. In fact, much more than 99%, as it were, of T4 and T3 are bound to thyroxine binding globulin, albumin, and prealbumin, formerly known as transthyretin. And these are then circulating, of course, to the many different tissues. And of course, virtually every tissue in the body is heavily dependent on a supply of thyroid hormone to function normally. But pregnancy changes things dramatically for the system because, of course, there is now an extra demand for thyroid hormone coming from the developing fetus. And this brings about many changes in the axis. So, for example, the average thyroid gland in an iodine replete individual will increase by about 10% in size. If you're iodine deficient, then you may end up with an enlargement of 20 to 40%. The amount of iodine that you need every day goes up by 50%. The amount of thyroid hormone that you're actually producing rises by about 50%. And the amount of the binding proteins is also increasing, typically by about 50%. So there is a very dramatic additional requirement being placed upon the system in order to meet the demands of the developing fetus. And of course, there are other important changes going on. So the presence of HCG, which, as I mentioned yesterday, shares a common alpha subunit with TSH, means that we start to see changes in how the axis is responding, because as the HCG levels rise, that HCG starts to spill over and have activity on the TSH receptor. And not surprisingly, therefore, the TSH levels actually start to fall. And if you actually look at individuals with rising HCG, if the HCG exceeds 200,000 in multiple pregnancies, about 2/3 of those ladies will have actually a fully suppressed TSH as a consequence of that. And once the HCG levels rise above 400,000 international units, you will actually see the TSH virtually universally suppressed. So we need to be aware that the reference range for TSH in pregnancy is naturally changing. Now, as the HCG is activating the TSH receptor, we also see that the free thyroid hormone levels will rise. In addition, as I mentioned, the binding proteins are going up significantly from fairly early on in the first trimester, and that means that if instead of measuring free hormones, you're measuring total thyroid hormones, you will also see those rise. So if you want to use total thyroxine, for example, as an indicator of thyroid status in a pregnant patient, you need to revise your total thyroid hormone reference range. And in fact, you need to increase it by about 50% compared to the non-pregnant patient. As we go on through pregnancy, and for example, HCG levels start to fall, the TSH starts to rise again typically, the total T4 levels are maintained, and free T4 levels, which I'm going to touch upon again in a moment, actually will generally start to come back down. But one of the big questions here is actually whether you can trust the free T4 level that your laboratory is actually telling you. And that's because the assay is now completely perturbed in the pregnant patient. So not many people are aware of how the laboratory actually is measuring the hormones that you are acting on. But it's important to stop and think about this, because then you'll understand why the results may potentially mislead you. So when we measure T4 or T3, we use what's known as a standard competition assay. That means there are a fixed number of binding sites within the assay to which either the patient's endogenous T4 or T3, shown by the red symbol here, can bind, but it's a direct competition with a fixed amount of a competitor, an analog of T4 or T3, here denoted by the red symbol with the star on it. So there are two fixed entities in this assay, the number of binding sites and the number of competing labeled analog. And the variable is the patient's endogenous thyroxine. And you can imagine that the more endogenous thyroxine that there is in there, the less binding sites will be occupied by the fixed amount of competing T4 analog. And then when you do your fluorescence assay, you get a lower readout if there's more endogenous T4 and vice versa. So if there's little in the way of endogenous T4, then there's more opportunity for the analog to bind to those sites. However, every single laboratory sets its assay up very, very carefully and calibrates its assay to meet certain conditions, including the binding content of the blood. And so, for example, if we see a change in TBG or if we see a change in albumin, the performance of that assay will differ. And what happens in pregnancy? Albumin goes down, TBG rises steeply. And as TBG rises steeply, the free T4 assay starts to overread. It starts to give you a value which is higher than the T4 if you measure it using a gold standard method such as mass spectrometry or equilibrium dialysis. So when the laboratory is reporting these T4 levels to you, and virtually every single one of you will be using this type of assay because it's the fast, quick assay that gives you a result the same day, the chances are it's actually giving you a T4 level which is not truly reflective of the T4 in that patient. And it's really important to understand that. Now, for the most part, as long as you're using the same assay in the same patient throughout pregnancy, at least you have a longitudinal set of values to compare. But please bear in mind that your assay might not be giving you what you think. So my first set of important messages in relation to pregnancy are that we need to think very carefully about the reference ranges. Ideally, we should be using population and trimester-specific T4 and TSH reference ranges. Ideally, they should have been derived locally in ladies who are TPO antibody negative, euthyroid and with normal iodine intake, and without thyroid disease. The chance of anybody generating those reference ranges themselves is pretty low, of course. So what we have to do is to adopt the reference ranges of others who've used those assays in similar situations. That often essentially means using the kit manufacturer's assays, and actually working out just how they've developed those reference ranges can be quite challenging. If you cannot do that, then your next best bet is to assume that TSH can drop almost to undetectable in the first trimester, and that the upper limit of reference should probably be 4 milliliters per litre, and that is quite different now to the previous recommendations around 2.5. If you're going to measure T4, by all means use a free T4 assay, But if you're unsure about what's going on, reverting to an old-fashioned total T4 assay, but allowing for the fact that the upper limit of the reference is about 50% higher is not a bad thing to do. And don't make the mistake of measuring iodine in your patient to try and judge the iodine status of that individual, because spot measurements of iodine in a given individual are highly unreliable, and indeed 24-hour urinary iodines are not particularly reliable either. At a population level, yes, know what the iodine status of your population is, but don't try measuring it for an individual, because it's highly unreliable doing a measurement on one day compared to another. What about iodine? Well, iodine is really crucial, of course, because, as we know, iodine is absolutely the cornerstone of the generation of thyroid hormone with its incorporation onto tyrosine residues in thyroglobulin. So we now have some pretty clear guidance as to what optimal iodine intake should be. In preconception phases, it should be around about 150 to 200 micrograms a day. Once we're actually in pregnancy, we're looking at a slightly higher requirement, somewhere around 150 to 250 micrograms a day. We really probably don't recommend single large doses unless you're really living in an area where you cannot get access to iodized salt or indeed iodine supplements. In that situation, you can just use a fairly large single dose, and that will protect both mum and fetus for 6 to 12 months. Generally, we don't recommend iodine supplementation to patients who are actually overtly hypothyroid, because it can exacerbate it, or if you're already hypothyroid on thyroxine. But that's a bit of a matter of a debate sometimes, because of course the fetus is still requiring some iodine for its own thyroid production. But equally, we don't want too much iodine. So avoid excessive iodine, more than 500 micrograms a day. And actually the big hazard here is being completely unaware of other sources of iodine, such as diets. If you take kelp in the diet, it contains many milligrams of iodine per day. Or if your patient has to be on amiodarone or another agent such as that, then again, these contain absolutely huge amounts of iodine. Amiodarone has 75 milligrams of iodine per 200 milligram tablet. So be aware of other sources of iodine. Okay, so what about dealing with overt hypothyroidism in pregnancy? What level of TSH is desirable ahead of pregnancy? What are the consequences if we don't adequately treat during pregnancy? And how can we make sure that we avoid inadequate treatment? Well, there are many complications. If you allow your patient to run into pregnancy with overt hypothyroidism, you can see here many different potential complications, and down the side I've put the odds ratios if you compare the rates of these individual events compared to euthyroid ladies. So this is a pretty undesirable place to be and a pretty indefensible place to be. Also, we know that there is a concern regarding the IQ of the offspring of ladies who are overtly hypothyroid. And you can see that the mean IQ score between those who are hypothyroid and those who are controls is around about 7 points. Might not sound a lot, but actually that can be quite a significant difference in terms of long-term outcome for those individuals. And it does seem to worsen the more dramatic the degree of hypothyroidism as judged by the height of the TSH. So what can we do to make sure we optimize management of hypothyroidism in pregnancy? In essence, we're trying to be proactive here if we know we've got a hypothyroid patient. So here we are slightly tighter with our target for TSH preconception, aiming for less than 2.5 milliunits per litre. We recommend that you empirically increase the thyroxine dose early in pregnancy, so you can up the dose, for example, on 2 or 3 days a week, so aiming for an increase of 20 to 30% from a very early stage, pretty much as soon as the pregnancy is confirmed or even potentially sooner. And we need to monitor regularly. We should be checking thyroid status pretty much every month, at least to the mid-trimester, and then also checking again at least once around 30 weeks and possibly more depending on the clinical situation. And we're being proactive here. We're predicting dose adjustments. We're trying not to allow the TSH to drift too high. And for the most part, and this is because we know that there is a slight difference in patients who are receiving exogenous thyroxine compared to their own thyroxine in terms of normal homeostasis, we're aiming for TSH generally, which is in the lower part of that reference range, even accepting that the reference range is now a little broader than it was previously. And what do we do after delivery? Well, we pretty much put the patient's thyroxine back down to its normal level. I tend to do that straight away. Some people like to wait a couple of weeks, but then checking the thyroid function test again at 6 weeks. So as you can see, this is entirely about being proactive in the management of these patients. What about subclinical hypothyroidism, though? The condition essentially where patients have raised TSH levels, but for the most part, essentially normal free thyroid hormone levels. Is this associated with pregnancy loss? Is it associated with premature delivery and other adverse pregnancy outcomes? And does it have consequences for the neurocognitive development of the offspring? Well, the answer is that yes, there is again evidence. For example, here, my good colleague from Birmingham, Christine Bolert, and colleagues have put together a meta-analysis of studies from more than 2,500 patients compared to controls, and we can see that subclinical hypothyroidism is associated with an increased risk of pregnancy loss and with adverse pregnancy outcomes. Interestingly, unlike in overt hypothyroidism, however, the two major studies to date which have looked to intervene to potentially change the neurodevelopmental outcomes for the offspring have not been able to show benefits. If you go back to the original study done by the Cardiff group led by John Lazarus, they replaced thyroid hormone at 13 weeks onwards and showed no difference in IQ for those children at 3 years. And then the more recent publication in the New England with a randomized trial of thyroxine for subclinical hypothyroidism or for patients with isolated hypothyroxemia in a very large number of pregnancies and treating a significant number of patients, again, we're not able to show any significant difference in IQ at 5 years. However, there is a big cautionary note for these studies, and that is that if you look at the time point at which the treatment commenced, it was at 13 weeks in the first study, later in the second study, by which time the fetal thyroid is actually there and functioning. And an important question is, could we make a difference here if we were able to act sooner and earlier? And we don't know the answer to that yet, but it wouldn't be a complete surprise if doing so was to produce some additional benefits. So I think there's still some unknowns here. And there is this intriguing data from Robin Peters and Tim Korovar from the Rotterdam group at Erasmus, showing that you can correlate childhood IQ at 6 to 8 years with free thyroid hormone concentrations during gestation. Here taking on the left-hand side individuals with a full range of T4 variants, including people with overt hypothyroidism or thyrotoxicosis, or on the right-hand side, excluding those with overt disease. And although the y-axis is not really showing a major difference in terms of IQ, it's still statistically significant if you're overtly hypothyroid or thyrotoxic that the IQ in the offspring is lower. And it's intriguing, actually, that the IQ goes down with the slightly higher T4 concentrations, because in that thyroid study from Cardiff, where they gave thyroxine replacement from 13 weeks onwards, they actually used quite large doses, and it's interesting that some of those patients were then slightly overtreated, and you do wonder whether some of the lack of efficacy there could have been due to the fact that they'd actually almost gone to the other extreme. So the key messages here are that treating subclinical hypothyroidism in pregnancy, you probably have to take account of the thyroid peroxidase antibody status. If the TSH is greater than the reference range, then yes, we go on and treat. If the TSH is between 2.5 and the upper limit of the reference range, then it becomes an individual patient decision. If the TSH is truly less than 2.5, then we don't treat at the moment. If you're TPO antibody negative, then again, slightly different recommendations. TSH more than 10, then T4 recommended thyroxine. If your TSH is lying between the upper limit of reference range and 10, then we can think about it on an individual basis. If the TSH is actually under the upper limit of the reference range, or 4 if you're adopting the other value, then at the moment we're not recommending treating. A very brief word about isolated hypothyroxemia in pregnancy. This is the individual who's got a low T4, but the TSH is not elevated. Now that might be due to various issues. It could be an assay issue. You sometimes see this in patients who are iodine deficient, or it could be, amongst other things, for example, a patient with central thyroid disease. If you look at the adverse outcome data for this phenomena, so this is not with a raised TSH, this is just a slightly low T4, at the moment the data suggests that there may be some adversity, but the statistical significance is only there for one parameter. Of course, there's a concern that, again, this could transmit to being associated with impaired cognitive function in the offspring, but at the moment we do not have evidence or interventional trials that support replacing thyroxine in these individuals. And again, I allude to the point that in the CAT study, when the slightly higher doses of thyroxine replacement were given, some of those mothers were actually rendered slightly thyrotoxic. So I think, again, we need to be quite careful here at this present time in terms of whether we should or should not treat this. And in fact, this is represented quite nicely by disagreement between the ATA, who do not recommend treatment at the moment for this condition, and the European Thyroid Association, who say that you might wish to consider this on an individual basis. What about antithyroid peroxidase antibodies? And now we're talking, interestingly, about the presence of the antibodies even in euthyroid women. There appears to be evidence that these may be associated with a higher rate of miscarriage, and that's the outcome of the meta-analysis of many studies, and also with premature delivery. Again, a smaller number of studies, but you can see that when they're combined, there seems to be a slight increase in the rate of preterm delivery in those with TPO antibody positivity. So what do we recommend for patients who are actually euthyroid at this stage, but who have got positive antibodies? Well, the first thing to do is we need to watch their thyroid function carefully, because, of course, they're much more likely to develop overt hypothyroidism than the lady who doesn't have positive TPO antibodies. However, interestingly, at this time, there is still insufficient evidence that giving thyroxine to these patients reduces the risk of pregnancy loss. We do not have that data convincingly, despite a lot of people wanting to automatically give thyroxine. Now, of course, thyroxine is a relatively safe treatment if it's used in low dose, so it's perhaps not unreasonable to consider replacement in ladies who've had a prior pregnancy loss. But remember, we don't have a lot of evidence for this. And there's not evidence at the moment to recommend levothyroxine to prevent preterm delivery. And also, just in case you're thinking about the option of selenium supplementation, which has a nice interaction, for example, with iodide status, at this stage it's not recommended here. We might get the answer, however, soon from two studies which are on running. This is a study, again, from the Birmingham group, which is actively seeking to find out whether a low-dose thyroxine supplementation early on, preconception, as it were, may help to reduce miscarriage rates. And that study is actually now in the phase of analysis. And there's a similar study looking at reduction in miscarriage being conducted by the group from Rotterdam. And then coming towards the end, what about fertility and thyroid status? Ladies with infertility, well, pretty obviously, if you've got overt hypothyroidism, we need to treat that. If we're looking at ladies who are TPO negative, but with subclinical hypothyroidism, and thinking about natural conception, then again, we don't have a lot of evidence for this, but probably because thyroxine is safe, it's reasonable to consider replacement here, or supplementation. But we don't, at the moment, have very good evidence to recommend thyroxine to improve fertility in euthyroid non-pregnant ladies who are TPO antibody positive. If we're going to consider IVF of different shapes and forms, then at the moment it's probably reasonable to target the TSH to the lower part of the normal range. Again, we don't have strong evidence, but it's probably not unreasonable to think about thyroxine replacement in a euthyroid lady who is TPO positive and undergoing assisted reproduction techniques. And here we do need to be quite vigilant. We should be looking at thyroid status before, or probably 1 to 2 weeks after, not at the time, please, of the assisted reproduction. It's extremely difficult to interpret the results at that point. And then if we see the TSH rise, as can occur in this situation, then we generally recommend treatment as per standard hypothyroidism. Now, with all that information in mind, I now want to test you out and see whether we're going to make the right decision. So I'm going to present you a case of a lady who came to me, having been managed by another centre, looking for an explanation and answer as to what had happened. She'd come in mid-pregnancy, 21 weeks, antenatal checks, saying she was tired. There was nothing else of note, and she had no thyroid history or endocrine history at all. She was completely clinically euthyroid. There was no goiter, and the examination was otherwise normal for gestation. However, her free T4 was 10 and her TSH was 25.7. Her TPO antibody status was negative. Can I just ask for a show of hands in the room, who would give this patient thyroxine? Okay, who would not give this patient thyroxine? Okay, well, the only hand up is one taking a photo of the screen, so I'll assume that that means everybody here is otherwise minded to give thyroxine. So she was started on thyroxine, and this is what happened in the second to third trimester. Her T4 rose, so it was now towards the upper limit of the reference range, but the TSH did not come down. Her thyroid function test was checked again in the third trimester, now taking 100 micrograms a day, and she was overtly thyrotoxic with a TSH which was fully suppressed. This is the sobering lesson. This is treating the number and not the patient. Here, there is a major discrepancy between two laboratory samples taken at the same time. This is the same blood sample going to two different laboratories, one of which tells us the patient is actually potentially euthyroid, that's the value from the Roche assay, hypothyroid from the Roche assay, and the other one from the Siemens assay, or indeed a third assay, the Perkin-Elmer assay, showing the patient is overtly thyrotoxic. This is entirely assay interference. This patient is normal. This patient has been given iatrogenic thyrotoxicosis. And this is because the assay is very vulnerable to interference and can lead to an apparent signal, even when there is no TSH there, by the very presence of the patient having a circulating, what we call heterophilic antibody in the patient's blood. And we can easily exclude that by doing what's known as a dilution study, because in a patient with genuine hypothyroidism, when we dilute the TSH, when you then back multiply, you get the same reading, whereas in a patient where it's entirely spurious, artificial, and entirely the consequence of an interfering antibody, as you do the dilution, it disappears. So in summary, I think I've highlighted that we now have some recent evidence suggesting we should change what we define as abnormal thyroid function and what we use as reference ranges. And I think it is important to make sure that we don't over-treat people. There has been a tendency now for the last 5 to 6 or even longer years to give more people thyroxine than perhaps need it. The treatment of subclinical hypothyroidism does, to a degree, depend on the thyroid antibody status of the patient. The issue around isolated hypothyroxinemia is not resolved. And at the moment, we are still waiting for evidence as to what we should do in euthyroid patients who are TPO antibody positive, although we may be inclined to give thyroxine supplementation. And of course, when we're using assisted reproduction therapy techniques, the most important thing is to keep a close eye on our patients. But as I showed in the last case, our very, very first rule of medicine must be first do no harm. Please don't just treat the numbers in front of you. Please look at the patient in totality. Otherwise, you may finish it with sequelae which are actually entirely iatrogenic. I'll finish by acknowledging all my colleagues who I work closely with in Cambridge, the funding bodies who support our work, and also my good friend and colleague from Birmingham, Christine Bohlert, and I'd be very happy with the rest to take any questions. Thank you very much for your attention.